Hello, everybody. This is Maria Brown. As I said that I will try to develop audio and do lectures from home so that we can have a reverse model of studying, doing lectures at home and doing practical and discuss cases in class. So I'm doing this for the first time. We might have challenges, I might have glitches, so please bear with me. But I do hope that this will work and we will all have a better experience and learn more. So let us get started. I decided to do it from chapter 9 to help you with upcoming quiz, and also because heart is a relatively complex organ and cardiovascular disease is also one of the major #1 diseases, leading mortality and morbidity. So let's see how we can work. By the way, the video is off because nobody is in the room. When we decide to make it live and you are participating when I'm recording, then I will have video on. As usual, we start with covering structure and the function. And structure of the heart is, as I said, relatively complex, and here I was able to pull a picture. Let's see if we can, oops, it's not the right one. Okay, let's do this. Oh. See? We already have glitches. I just wanted to show you the picture because it's always, I believe, it's better to see than just to listen. Wow, I think I should stop. Okay, I was able to pull another website and hopefully you can follow me. And let's look on the picture of the heart. So as I mentioned already, it's quite complex in structure, and it has the complexity is that it has two atriums, right atrium and left atrium, that it's covered, it's on the other side. You can't see it very well. And right ventricle and left ventricle. So if you could just see that, or if we put it, let me use the tool. Okay, back to you. Hopefully you can see it. So on the right side, right atrium and right ventricle has deoxygenated blood. Deoxygenated blood. So that means that the blood that is coming from the rest of the body, from our legs, from our gut, from through inferior vena cava, and also from the top, superior vena cava, on the top you see vena cava, from our head, that all that is going to right atrium, and from there through the valve that is called tricuspid valve into the right ventricle. So you can, if you just compare the walls of right ventricle compared to the left side of the heart, left ventricle, there is a huge difference in the thickness of the ventricles. So you can imagine that structure defines function, right? The thinner the walls, the less function, the less stress right side of the heart has, because it's a relatively low pressure that it has to work against. Means that right ventricle pumps blood towards the lungs, and as you know, lung is a low pressure system compared to the left side of the heart, right, which is the red. in red. When oxygenated blood returns from the lungs to left atrium, then it goes just to the left ventricle through mitral valve, and then left ventricle compresses and pushes the blood towards the system, towards the aorta through aortic valve. So that's complexity. And aorta, you can see this is quite the thickest vessel in our body, and then it has a bifurcation, like 3 at the top. You can see 3 big vessels. Those are the bridging towards the heart itself and to the brain and to the rest of the body. So this is very basic in your book. There is also other pictures. You can see the blood flows, how it goes. But I just wanted for you again to see the difference, the structure, to atriums, to ventricles, and the division between right and left. So let's go back to our presentation and move forward. So here we connect everything to the function, and because heart is such an important organ to pump the blood against the resistance of the vessels of the rest of the body, in particular when it goes to aorta, you have seen how thick that vessel is. So it depends a lot, or highly dependent on oxygen supply, right? We talked a lot about that. If heart is not receiving enough oxygen, that affects, that leads to ischemia, and patients might experience symptoms, but if it's completely blocked, it may lead to myocardial infarction. So we will talk more about this later. So this is the muscle and the vessels, and here, if we try to, I don't know if it works, but let's try to see the vessels. I think I will not just go. In your book, figure 9.3, you can see the vessels on the right and left coronary artery. We talked a lot about those in class. If right is blocked, we would have issues with electricity, because in following, if you can stop here and follow the link below, you would see that pacemaker of the heart, how it works, how it supports automaticity of the heart. Okay, I will keep moving towards the next slide. So in the next slide, here I wanted to, hopefully by now you were able to see again that small video that presents how heart is able to actually regulate itself, and how beautifully it works, where electricity is like running through, being able to charge the charged and move the electric impulse starting from sinoatrial node in right atrium, which is called the natural pacemaker of the heart, into the AV node, which is at the border between right atrium and right ventricle. And then it goes down, right? It goes down through the interventricular septum towards the muscles of the right ventricle and left ventricle. And those bundles are called bundle of His. They stimulate the ventricles. Sometimes those bundles can be, so any of the structure can be affected by the lack of proper oxygenation, and if we have this one affected, which is the most important, so you can imagine that there could be arrhythmia very quickly, and the below structures, AV node, tries to pick up and to be able to send some signal to the ventricles, because if ventricles are not able to pump, to be stimulated and to pump blood out, so the blood will stall, and that would cause, first of all, the property of the blood, right, it immediately starts clotting, but the tissue like brain and heart itself and all other key tissues cannot survive without oxygen. So that is every minute, if we cannot restart the heart within 10 minutes, this is death. So every minute we are losing 10% of the chance to live. So that is such an important tissue here, such an important fibers, those electrical fibers, that they were given rise from neural tissue. They are derivatives from neural tissue. They are coming from neural crest, which is a part of ectoderm. So let's move on. And now we start covering most serious medical conditions related to heart. We will just name them. And then in the second part, we will revisit some of them again, and we will just look at important conditions through 3 different perspectives: if they are congenital, if they are inflammatory degenerative, or they are neoplastic. So first, let's cover most important serious problems. So the most important serious problems are all having relationship with atherosclerosis, and we talked a lot about this, that atherosclerosis is really an epidemic in the United States. It leads to cardiac and cardiovascular dysfunction. And why? We all know, because the vessel of the heart is so critical organ, requires a lot of blood and oxygen to be delivered in order to maintain the function, right? And then if the function is being somewhat compromised because of the structure, and this is the guy, atherosclerotic plaques obstruct the lumen of the key arteries, which is the right coronary artery and left coronary artery. So that may lead to obstruction, lack of oxygen, and patients would experience pain, discomfort, shortness of breath. That all would also depend on the side, right? Which one, if it's a right or left coronary artery is being affected. But it starts with the symptoms. Our body sends us the signals. It will be the chest pain and difficulty breathing. Then, if most of the lumen is obstructed, that can actually lead to myocardial infarction, which is ischemia and necrosis, right? If it's more than 20 minutes, it leads to myocardial infarction, means the death of the vessels. But before, at least the death of the vessels, remember that those tissues that we talked about, the tissue related to automaticity of the heart, that SA node, AV node, bundle of His, if they are not, they also need, in order to proper function, they also need to receive oxygen. If they are not receiving enough oxygen, the heart is experiencing presented with arrhythmia. And actually arrhythmia, it's the first leading, the most common cause of early death right after in myocardial infarction is arrhythmia. So in other words, people die from MI not because the muscular tissue died, it takes 20 minutes for muscular tissue to die, but arrhythmia because those SA needles, they belong from neural tissue, and neural tissue takes 5 to 10 minutes to die. So it's because of them, it's because of that the tissue that is responsible for automaticity. And then, so those are 2 most important, right? Gradually, angina and MI. But in the long term, if patients survive, we have chronic heart failure, which is CHF, and that is a long suffering. So we will talk more about this by the end of this lecture. Let's move on. If we divide all problems, that whatever I just mentioned, onto the left and right side, that the medical problems would be somewhat different. Just to remind you again, so on the left side of the heart, right, left side, it starts, the blood comes from lung, which is oxygenated, a lot of oxygen, ready to be delivered to the rest of the body. It has to go through the left atrium, and I suggest you you can stop, pull out the picture of the heart and see while I'm talking, if that is helpful to you. In any case, oxygenated blood going through heart into the aorta and to the rest of the body, while deoxygenated means lack of oxygen but lots of CO2. It's coming on the right side, right? And from right side, this would come from leg, right side of the heart, and lungs. So what kind of diseases we can have on left side or on the right side? So on left side, and we are talking about the heart here, right? So the heart has, if we have atherosclerosis that we talked previously, that affects vessels, and particularly those big vessels like aorta. So imagine that aorta has a lot of stiffness because it becomes calcified, the lumen is narrowed. Heart has to work harder, push against a very stiff aorta. So that's why the left ventricle, remember I mentioned that left ventricle has to be thicker because it has to work harder. It has to overcome the pressure, and mean arterial pressure on the left side will be around 100, right? So this is one of the issues, that heart has to work hard against something else outside the boundaries of the heart. But here it's an example how heart is affected because of intrinsic problem inside the heart. And as an example, it could be multiple different organs, but here we are talking about valve. I mentioned that heart has 4 valves, right? 2 valves between the atrium and ventricle, and 2 valves. One is aortic on the left side, another one is pulmonic on the right side. The blood is going out to the heart, out of the heart. Those are aortic and pulmonic. So if we are talking about mitral valve, which is the valve that separates left atrium from left ventricle, that valve it's a heavy-duty valve. It has a lot to carry because of high pressure, and sometimes, particularly in less developed countries, people can be affected with a disease that probably you've had, with rheumatoid arthritis and rheumatic fever. This is secondary to a strep throat infection that causes the strep throat, and then it's leading to autoimmune reaction that somehow loves mitral valve most, and it actually either destroys it, or all this chronic inflammation leads to calcification and stiffness of the valve. So if valve is either stiff to narrow, or it's become incompetent if it becomes too wide, so it can be either or. But because of the valve problem, heart is having to work harder. So it's just an example of the intrinsic problem of the heart that can affect the rest of the tissue of the heart. And also here, so this is on the left side. This is the problem on the right side. Sometimes people might have problems with the lungs, primarily in the lungs, like COPD or pulmonary hypertension. So that can lead the heart to work harder to push the blood against the stiff lungs. But also the lung, and you will see the lung are so affected, so connected to the blood. So if the heart is suffering, the lung is suffering secondarily, vice versa. And if primarily heart is affected, so the lung will be secondary, and that would be in chronic heart failure, we will see later, and vice versa, core pulmonale, when there is COPD, for example, this side, here we go, the right side will suffer. So those two, they're interrelated. Sometimes left side of the heart starts to decompensating, and the right side picks up. Or if we have a pulmonary disease first, then right side will be affected, and then left will catch up. They have to, because they are connected, there are two cycles, independent, right? Left goes separately, right separately, but if one is decompensated, another one will follow up. So there is one more issue. We'll be back to this in congenital, when we cover congenital diseases, but this is something related to the interseptal defect, so interventricular septal defect. So this is the lining that actually separates. It's a very stiff, naturally has a lot of collagen tissue, less muscle, but this is something that separates left ventricle from left atrium. Sometimes it can be affected genetically. There is a change, mutation in one of the genes, and that leads potentially in the problems. Usually people can live fine unless they are competitive athletes. That can lead to a disease that I will just touch upon just in a few minutes. Okay, so now, as I said, we will have to cover diseases from different perspectives. So, and another classification could be if all these diseases to divide in acute and chronic. So acute, those that are happening like quickly, the patient can quickly present, feels like everything was fine, and all of a sudden patients experiences symptoms, and those could be very frightening and scary. And that because the event happened quickly. It doesn't mean that there was no underlying problem. There always is. It's just, pardon me, it's just that it was up to the point compensated. And here we go, almost 80% of the lumen is blocked, either because we have embolus that travels from somewhere, or the patient probably had an excess in physical activity that led to higher demand of the oxygen, and the symptoms became the heart was not able to keep up. Patients started experiencing symptoms. So here we go. Those are classical symptoms of acute coronary accident. As I said, women in class, women and particularly patients with diabetes may have a different atypical presentation, and sometimes it can be felt like the stomach ache, because, particularly in patients with diabetes, due to their underlying neuropathy. And diagnosis, usually the first thing that physicians do is electrocardiography, which actually shows if there is either ischemia or myocardial infarction. On the chronic side, so on another side of classification, chronic, those are the long-term existing. Patients know about them, and they are being compensated, and sometimes they can have exacerbation, but that can last very long. So typical presentation of this is congestive heart failure, which can be either the failure of the left side or the right side. Most commonly, it's on the left side, because left side, when patient experiences the symptom, that means that major part of the heart has been affected, and the major part is the left side of the heart. The right side still has to go through the same amount of blood. It's just that resistance of the lung that right side has to work against is lower. And there is much more demand on the left side because of that resistance of the vessels is much higher. So the symptoms would be very different. So now you can imagine if the left side of the heart that normally has to pump through the blood that comes from lung cannot do its job. There is a congestion, like always behind, and that behind would be lung. So lung will be flooded, and that means that patients will have difficulty breathing. They would have to sit and sleep almost in a sitting position, because if they lay down, they feel they do not have enough oxygen. They would experience shortness of breath. So this is on the left side, the compensation on the left side. On the right side, on the other hand, so if imagine the patient is having pneumonia, which is primarily, and the right side has to push against the inflamed lung. So the lung is not able to take all this blood because lung is fighting its own infection, could be. And lung we will talk in the next lecture. So the right side has to work much harder. And pneumonia is just one of the examples, could be many more serious even. But the fact is that the right heart might be decompensated, and then the patient would experience the congestion on the venal side, and we know that venal side has a lot of compliance ability. It can accommodate a lot of blood, but still there could be, like everywhere in the body, the patients would feel like these blue veins being very expanded, and it's also very uncomfortable feeling, but not to the same extent as on the compensation on the left side. And diagnosis, physical examination, right? The patient, as soon as patient expresses the symptoms, physicians can quickly guess which side, and then X-ray helps to identify if the problem, what's happening with the lung. Also, the X-ray is able to project the shape of the heart and the lungs. If we suspect that the problem is with the vessel, that heart is secondarily being affected because there is that chronic obstruction of the vessels that bring the blood. Like heart is experiencing chronic hypoxia, that would be able to detect through catheterization and potentially pull the clot or emboli out. So electrocardiography, I already talked about. Electroechography, that is an ultrasound technique. It's to see the shape of the heart and also the shape and the condition of the valves. Now, you know the valves are very important, because if the valves, like a gate, are not properly closed and open on time, there is always a congestion somewhere. So let's move on, and now starting to present the problems related to heart from either, depends when they occurred, right? If they are developmental, genetic, that the baby was born with this, or if they are acquired, or if they are neoplastic. So the first one, genetic and developmental, and I mentioned in class that many could happen because in the first week of embryon development, the tissue organogenesis is taking place, and heart is of course very important. And as you could see, the heart itself had neural tissue, right? Derivative of neural tissue, which is SA, V node, and all these bundles. Muscle, which is the specific type of muscle, cardiac muscle. It also has a lot of collagen fibers that are coming from mesoderm. So all this tissue has to come in the right time together, and by the 8th week. And if it's not, then the baby is being born with some of the conditions, could be very serious condition. But also after 8th week, up to 40 week, when the fetus is developing, also some other effects may happen, either infectious diseases or the underlying chronic diseases of the mother, like diabetes, can lead to a huge baby and huge heart. Here are a couple of examples that mostly are happening at the this first 8 weeks. So bicuspid aortic valve. So this is the valve, aortic. Aortic is the valve that actually separates left ventricle and aorta. Should be tricuspid. Sometimes it's bicuspid. So this is one of the very important mitral and aortic, two valves that have a heavy-duty job. And if one of them is congenitally defective, then we can suspect that people have a higher probability of getting insufficiency of that valve by the end of their lives. And that is usually, that can happen to aortic valve working hard. So even people with tricuspid, many of them have a so-called aortic stenosis, but with bicuspid, it's happened like 10, 15 years earlier. So a coarctation of aorta, this is the narrowing, like you have seen aorta, it's a very thick, powerful vessel. Sometimes it has, in the middle, it has a narrowing stenosis. So you can imagine if like all of a sudden there is a small road that is stenotic, we have immediately congestion prior to that, and that can affect and quickly lead to heart failure because of that extra effect that puts on heart. Here, AV, atrial ventricular septal defect, as ASD or VSD. So those are potentially more serious, and why they are, they should not be defect, right? When there are windows, so-called in the heart, in embryonic, when the fetus is growing, that is absolutely normal. You should not know the details in this course unless you're interested, and then we could talk. But in adult life, as soon as baby is born, within 24 hours, the AV, the natural defect that was keeping the baby alive in utero is supposed to close. Sometimes it's not. And so it depends how big is that opening. But if it's open, if there is a big hole, particularly in the ventricular septal, in ventricular septum, means between two ventricles. So you can imagine that on the left side of the heart, the pressure is much higher than on the right side. So if the pressure is much higher on the left, the blood can go from left to heart, to right. So that is potentially a better way, it's a better outcome. It, of course, in current healthcare system, that can be detected early, it can be repaired. The problem is more serious when the defect is in a way that the pressure, so the pressure is on the right side is more than on the left. So if the pressure is on the right is more than the left, that non-oxygenated blood from the right heart that is supposed to go to lungs and oxygenate will be pumping through that hole in the ventricles into the left heart. So imagine non-oxygenated blue blood from right side, it's going through the hole in the ventricle to the left side. So the baby will turn blue. And this is something that has to be corrected very quickly, otherwise that can lead to decompensation of the heart, and of course it prevents the development of the baby. So it can be very serious. And one of the quite disturbing anatomical defect, it's a tetralogy of Fallot, has 4 different key aspects in this, but all of them is the defect of one big of improper separating of both left atrium and right atrium. So then we are getting too big aorta on the left side and very constricted vessels on the pulmonary side. So that is becoming stenotic. This is too wide. In any case, this is a cyanotic. This is where the blood from right side, non-oxygenated, is being actually pumped into the left side of the body, and that needs to be corrected. That's all what you need to know. That genetic developmental diseases, they are being considered for surgical correction, because this is the defect, inborn defect in the structure that will not support proper function of the heart. Those are just few examples. There are many, many more. And one more, as you could see here in red, I marked genetic and development all in red. So this one, hypertrophic, it all belongs into it. The name is misleading because it's like cardiomyopathy, which is mostly acquired, but this particular is a bone. This is what I mentioned, that there is a fake interventricular septum, that it's a genetic disease, and people are fine unless they are competitive, involved in competitive sports. Then they could actually drop that on the field, because that if you see in your picture or in your book on a heart, so that the septum that separates left and right ventricle is so thick that the heart cannot dilate, means relax and fill in. If they are working hard and running, when you are running, right, your heart is working very hard, very quickly. So if heart rate is very high, it is not able to fill in properly. If it's not able to fill in properly, the patient can die. And this is what happens, sudden death on the field. Hypertrophic obstructive cardiomyopathy. Okay, now we are moving towards the acquired intrinsic cardiac muscle defect. And I already touched on CHF, which is congenital heart failure, and mostly it's related to the left side and dilated due to ischemia or post-MI period, but also could be due to alcohol and in pregnancy. Alcohol, because the constant exposure to alcohol is actually prevents proper energy accumulation, and heart is so hungry in energy, so that leads into dilated cardiomyopathy. Restrictive, it's another side, so you can imagine that heart muscles are being stuffed with something extra, and this is amyloidosis. It's a protein fiber that leads to very stiff, like grilled muscle, and also exposure to radiation, chemotherapy, particularly with doxorubicin. It's one of the drugs that used in chemotherapy complex treatment can lead to restrictive cardiomyopathy, which is it's a permanent restrictive as well as dilated. It's a permanent effect to a heart, which is why now you know, because heart cannot regenerate, it degenerates, and it degenerates through the inflammation and fiber, very stiff fiber repair, completion that will never actually be able to maintain the same function. Next, here, since we are now touching, again, lots of repetition, inflammatory degenerative, it's at a pathophysiological step that heart is going through if being deprived, right? The most important from oxygen, the most important due to atherosclerosis. And the mechanism you already know, it's a plaque formation, right? It may be fatal if it's acute. Clinical presentation is a gradual increase starting from angina to, it could be arrhythmia, to MI, myocardial infarction. Treatment, almost every big hospital is having now a cardiac catheterization lab, where people with the first symptoms, when they're coming to the hospital, immediately ACG is done, and we can see what's how heart is being suffered. And then if it's proven that we have ST elevation, means proven on ACG that there is a ACG, AKG, it's the same, that there is a MI, they can be taken into the lab and do angioplasty. Angioplasty, you have seen the video I posted in one of the prior lectures when physicians go and actually able to pull out the plug and insert over there the stent. Okay, this is when you have only one vessel obstructed. When there is all of them, particularly in people who are having atherosclerosis, it's a general disease. It's not just a disease of one vessel. So potentially some people may need bypass graft because all vessels are affected, and it would not help just to put a stent in one, so they would be taking the graft from their saphenous vein in the leg and put, it's like a collateral vessels for the heart. If that is not possible, or the hospital does not have catheterization lab, and within a few hours we can actually clot can be busted with the drugs. We skip chapter 11 because it's super complex, but just few words that we have drugs. This is one of them, plasmine. It's derived in the lab. Streptokinase was before, and this one is less side effects. Newer drug that is able to clot bust the clot, excuse me, within 3 to 4.5 hours from the inception. So here, the previous one was mostly about the muscle, right? The covering the muscles of the heart. But the heart, as you know, has other structures, right? And has a lot of collagen fibers as an intrinsic part of the in between the musculature. It just keeps that heart in a specific shape. So you can imagine if those collagen fibers are being somewhat affected also, and there are a couple of examples that are genetically actually caused. There could be deficiency in how the fibers are being built, so they are not that strong. And if they're not that strong, they can actually loosen up. And if they are loosening up, so we would have so-called aneurysm, which is like weakening of the vessel, of one side of the vessel, like out punching on one side. It's like when you're trying to blow the balloon, it just goes in one side. So this is exactly what's happening in aneurysm. People can live with that out punching for many years. However, if that is expanding, or it's a perfect place for forming the clots, right? And then the clots can be then traveling around and causing all kinds of problems. Or it can actually rupture, and then we have aneurysm rupture. This is actually sudden death, almost 100%. So these are the diseases that can lead to death momentarily, that is not affected to the muscles primarily, but to collagen fibers. Valves, we already touched on as an example of mitral valve, but valves can be affected in different ways. Rheumatic heart disease mostly loves mitral valve. On the right side, we have tricuspid valve, also between right atrium and right ventricle. That valve is mostly affected in drug users because they are injecting themselves with all kinds of chemical substances and also bacteria. that bacteria, it loves to live on tricuspid valve. And causing, of course, endocarditis, because this would be endo, means intima, the inner side of the heart from inside. That bacteria can also cause endocarditis. And one of the specific disease that you might hear later in practice in other courses, and as a professional, AFib, it's a very prevalent disease, atrial fibrillation. That is a disease when a patient has a mitral valve affected, that is mitral stenosis, right? The gate is not opening properly, stenosis. Then left atrium that is above left ventricle has to work harder. So that leads to hypertrophy, means expanding in size, and also dilation potentially. That could, and the disease is called atrial fibrillation. That causes all kinds of issues, including, because it's dilated, perfect place for clots. Anything where we have a dilation of the arteries or veins, we have clots forming. Those clots can be pumped out then from the heart and cause issues. People with AFib are lifetime on warfarin, oxarialto, that you can see on ads on TV. And the last point, we are coming to organ failure. So organ failure also can be acute, right, and chronic. So just repetition, lots of repetition. Then organ failure, it's when heart is not able to perform its job. And mostly when it's a heart issue, we are having cardiogenic shock. And we have had about other types of shocks, right, when we are covering vascular diseases. They could be neurogenic, septic. Here we have cardiogenic. Cardiogenic, the heart is either acute myocardial infarction or decompensation of VHF. Heart is not pumping. So there is an immediate stall that leads to acute symptom presentation in the patients. Either it could be arrhythmia, because now you know those A, V, S, A nodes are being affected and they immediately lead to arrhythmia. Or there could be congestive, the congestion in the lungs and dyspnea, patient's perfusion, cold sweating, blue-gray King's color. So remember, we were covering in kids, the blue kids, the defect in the heart, intrinsic defect in the heart, there could be blue lips in the kid, in the child. Here, it's a grayish skin color in these patients that have decompensated acute cardiogenic shock. And in chronic, it's a chronic suffering for a long time. People have edema in the leg, so at the end, it might start in the left, but it comes, the whole heart is being decompensated. So the people have both. Lungs are being flooded because left heart cannot properly function, and right side of the heart also cannot function. So people would have edema in their legs. And of course, difficulty breathing, difficulty moving. And this is not a nice place to be. But there are many medications that can partially help. And if they are not, many patients potentially have been the candidates for heart transplant. Many of them, many times. Okay, so that's all. And I hope that I will be able to share this with you and you can hear this. Sorry, somehow took so much time. Okay, bye.